Myself, Dr. Kavya from Srinivas Institute of Medical Science and Research Center, Mukka, Shin, Mangalore. My co-author is Dr. Serene Balaji, Assistant Professor from MAMC, New Delhi. My topic is ultrasound and MRI correlation in cases of complex cystic lesions of the breast. Introduction. Complex cystic lesions contain cystic and solid components. It can be divided as type 1, which is thick outer wall and internal septae, or both. Type 2 is having intracystic variety with one or more discrete solid mural nodules. Type 3, mixed cystic and solid components with at least 50% of it being cystic portion. Type 4, at least 50% of the solid component should be there with eccentric or central cystic foci. Materials and methods. Study was conducted over a period of 2 years. 160 patients with palpable or mammographically detected lesions were evaluated by ultrasound, and 44 patients of 50 sonographically detected complex cystic lesions were included. Morphological assessment and subclassification was done by ultrasound using linear probe. Complex cystic lesions were assessed for shape, margin, orientation according to Beirat's subtype of complex cystic lesions. Dynamic contrast enhanced MRI, DWI, and MRS was then performed on 3 Tesla MRI machine using breast array coils. Out of 50 complex cystic lesions, 18 lesions were malignant, whereas 32 were benign. Age range varied from 15 to 70 years. Mean lesion size was 3.17 centimeters. 36% of the lesions were malignant. Rest of them included fibrocystic changes, which is 24%, and abscess were 14%. Rest as shown below. Out of various modalities, diffusion showed 100% sensitivity, and dynamic contrast enhanced MRI showed 94% accuracy rate. This chart shows various characteristics of malignant lesions. Malignant lesions are irregular and not circumscribed anti-parallel. They're mostly type 4 and shows heterogeneous enhancement. Diffusion restriction is positive for most of the cases, and they will show choline peak. Kinetic curve on DC MRI would be type 3. Here is a ultrasound image and MR image. Ultrasound image shows circumscribed oval shaped type 1 complex cystic lesion with thick walls, and no internal vascularity was noted. On a T2 weighted MR image, it shows hyperintense round and oval lesions. Few of the lesions showed fluid levels. ADC map shows absence of diffusion restriction in these lesions. Next picture showed ultrasound picture showed oval shaped circumscribed type 2 complex cystic lesions in parallel orientation with mural nodule which is shown by the curved arrow. On the post gadolinium enhanced axial image, it shows intensely enhancing mural nodule arising eccentrically from the wall of the lesion. Here, absence of choline peak on MR spectroscopy is noted. Dynamic analysis showed type 2 curve, and EDC map showed no diffusion restriction. This ultrasound image shows 50% of the lesion being cystic, which is a type 50% of the lesion being solid, which is a type 4 complex cystic lesion with solid component and multiple cleft. showing parallel orientation. Extended field of view shows the lesion in its entire extent in the B image. Absence of choline peak on MRS is noted. Post-gadolinium images showed heterogeneous enhancement in a leaf-like pattern. Multiple non-enhancing cystic areas can be seen. ADC map showed lack of diffusion restriction. Dynamic analysis showed type 1 curve. Discussion. Cystic changes in the breast demonstrated a high malignancy rate recorded as 36% in the current study. Significantly higher frequency of malignancy was observed among type 4 lesions in comparison with type 1 and type 2 lesions. Type 3 lesions fell short of statistical significance in comparison with type 4 lesions. Combined analysis stated frequency of malignancy in type 3 and type 4 cysts was significantly higher than in type 1 and type 2 cysts, whether assessed separately or together. Positive predictive value for malignancy, which when is positive and the lesion is actually malignant, was highest in type 4 lesions, which is around 70%. Malignant lesions predominantly exhibited heterogeneous enhancement pattern with type 3 kinetic curves noted in majority of the cases. All malignant lesions showed restricted diffusion on diffusion restriction. The mean apparent diffusion coefficient, that is ADC values, for malignant lesion were 0.72 into 10 to the power minus 3 millimeter square per second compared to 1.5 into 10 to the power minus 3 millimeter square per second for benign lesions, which is significantly lower. All malignant lesions except one exhibited a tall choline peak. Additionally, 4 benign lesions also displayed a raised choline peak. The presence of a raised choline peak was associated with significantly higher malignancy rate compared to benign lesions. In conclusion, ultrasound remains the mainstay of all cystic lesions for breast, including complex cystic lesion. Further, subclassification on grayscale can help differentiating benign versus malignant. MRI increases the confidence in differentiating benign lesions from the malignant. Combination of these modalities can achieve greater level of diagnostic confidence.